Thank you, David, for the introduction and for having me to present today. Just 1 second. So this is going to be, perfect. I hope, a quick presentation because I see we're running out of time, and I hope to convince you that transplantation and donation of a kidney is probably safe enough. So we'll just briefly look at CKD and look at transplantation, talk about the risks that go to the donor, and then we'll quickly look at what our take-home messages are. So as you all know, chronic kidney disease is very prevalent. It occurs in about 10% of our population, and in places like Africa, the prevalence of CKD is as high as 15 to 20%, and it tends to increase with age. And as you age, you know, the rates can go up to in excess of 20% as you become elderly. That is after the age of about 60, 65. So CKD is quite prevalent, and even with time, it gets worse. So in the early 2000s, the rates were much lower, but as we go into the 2010s and 2020s, the rates of CKD are going to be higher and higher. So that poses a problem because with the CKD, CKD increases your mortality. It tends to make you have a mortality way in excess of what is appropriate for your age. As you can see here, someone in the 20s to 30s, whereas their mortality, if they did not have CKD, is supposed to be 0.01%, it increases up to 5%, which is more than 50 times elevation of mortality. And most of this mortality is due to cardiovascular disease. So usually we have to put these people on dialysis as the only option. And indeed, dialysis are shown to be a lifesaver. Whether you do hemodialysis or peritoneal dialysis, your survival improves much significantly as compared to if you remain on conservative management. So we've done some good things with dialysis, but dialysis is just a stopgap. It's not perfect. So we usually have to just transplant these people. Unfortunately, not everyone is transplantable, but for those who are transplantable, the benefits are huge. If you get transplanted, your risk for dying or your chances of survival over time are way better compared to if you remain on dialysis. So definitely, a kidney transplant is much better than being on dialysis. Unfortunately, transplantation doesn't come without risks. The early months after transplantation, the first 100 days especially, have a high risk of death. But after 100 days, which is about 3 months, the risk of death due to transplantation as compared to staying on dialysis equalizes, and you start benefiting after 3 months. So we usually aim to keep our patients to live at least beyond 3 months, by which time the benefits of transplant become apparent, and they continue to remain apparent for years to come. And as you can see, over the long term, a person who has had a transplant as compared to someone who has never had a transplant, they gain years of life. Someone who gets a transplant at the age of 10 to 19 gains as much as 13 years of life expectancy or projected years of life. And someone in the 60s can gain up to 4 or 5 years due to a transplant. So transplantation really changes lives. It improves your quality of life, but more importantly, it improves your survival and adds years of life to you. So it's a good thing. It's a good thing. And usually we choose donors. We look for someone who is healthy, and we make sure they don't have, there are no contraindications that are apparent. Like, for example, the donor is not too young or not in a mental state to make an informed decision. We make sure there's no donor coercion. We make sure there's no illegal financial exchange, and we make sure that the donor does not have any psychiatric conditions. And those are probably the hardest contraindications we have. There are other contraindications that we look at, but usually those ones are looked at relatively, depending on the situation at hand. So as you can see, most of the time as nephrologists, we spend time trying to make the process of transplantation safe for the recipient. But what about the donor? Are there risks to the donor? So as like everything, and especially because it involves going to the operating theater, there are risks to the donor. And we usually look at these risks in two ways. There are immediate risks, which are usually just post-op risks related to the surgery itself. And there are risks that come over the long time because of the nephrectomy itself. Now, in the immediate post-op period, of course, you can die in theater. There is pain, you can get infection, either orthostatic pneumonia or wound infection. You can get blood clots. You can react to the anesthesia. You could be going in for laparoscopic nephrectomy, and then you end up getting it converted to open nephrectomy due to technical reasons, and therefore your recovery time becomes prolonged, and you get more pain than what you would have expected had you gotten a laparoscopic surgery. Sometimes you may need to go back to theater for reoperation, maybe because of bleeding. You may need to be readmitted for various reasons. You may develop hernias, you may develop intestinal obstruction. And among males, you might get testicular swelling and discomfort because of the surgery itself and from the venous congestion. The rates of these post-op risks are quite low. Death in itself only occurs in about 3 to 7 per 10,000 donations. So it's fairly low risk when you talk about death, and especially if you talk about death attributable directly to donation, which can be as low as 0.6 per 10,000 donations. In a few cases, you may have as much as 0.4% transfusion, maybe 0.3% vascular complications. And in general, we normally say that major complications would probably be somewhere between 3 and 6%, and minor complications, which are the many, including pain and a bit of bleeding, can be as high as 22%. So generally, in the short term, the post-op risks are not that common, and especially death from the operation is fairly rare. 3 to 7 per 10,000 is quite safe. So what are the risks of death following the operation? It's modulated by various things. The male sex is more prone to death from the surgery, up to 3 times as compared to females. And being Black confers more risk of death from the operation as compared to white or Hispanic people. Now, over the long term, there are other risks that can occur over the long term. Mostly, we're talking about mortality, we're talking about hypertension, we're talking about chronic kidney disease and end-stage renal disease requiring dialysis. So when we talk about mortality, this has been looked at, and there's been no adverse impact of living kidney donation on lifespan as compared to the general population. But when you look at the numbers and look at different strata of donors, there seems to be a slightly increased risk of mortality among older donors, male donors, Black donors, and those who have hypertension during the time of donation. So as much as donating does not confer risk in general over the long term of mortality, if you're older, if you're Black, if you're a man, and if you're hypertensive, your chances of dying in the long term are slightly heightened because of those factors. However, when you look at these long-term death rates from among donors who donated, they don't seem to be significantly high. They don't actually exceed the rates of matched controls. And this is just based on data which was done in the US, where they looked at the nutritional surveys. They looked at the rates of death among the general public, and they compare that to matched living kidney transplant donors, and the rates of death were not significantly high. So it's safe to say that over the long term, your risk of dying having donated a kidney are not significantly heightened, or are not significantly more compared to the general population. What about chronic kidney disease? The rates of dialysis among donors are about 180 per million per year, which is way less compared to the US average of 268 per million per year in the general population. So that is to say that donating a kidney does not really predispose you to end-stage renal disease and needing dialysis. However, when you look at certain strata and certain groups, this might not always hold. So among Black donors, among the obese, the rates of dialysis and chronic kidney disease are a bit higher. And those are probably the risk groups that we might need to pay a bit more attention to. When you talk about hypertension in the long term, there's a tendency for higher blood pressure among people who've donated a kidney, and they also have a higher risk of hypertension. Compared to matched controls, people who've donated their kidneys can have an elevation of blood pressure of up to 6 millimeters of mercury systolic and 4 millimeters of mercury diastolic as compared to the general population. And this is especially so among those who are Black and those who are obese. Now, there's this interesting study that came in 2018 that looked at US data from 1994 to I think 2016, and over a 22-year period, about 22-year period of data. And what they saw is among 123,000 donors, there was only about 200 who developed end-stage renal disease over that time. And when you calculate that, it comes to about somewhere between 80 and 100 per million per year of end-stage renal disease, which is again much less than the US average of 268. And what they noticed is again the same things. Being Black tended to increase your risk of getting end-stage renal disease, and especially among Black young donors tended to have this risk more. Among the whites, it was the elderly whites who tended to have a higher risk of end-stage renal disease. They noticed that males have a higher risk of developing kidney failure. Those who are obese, those who have a lower GFR at the time of donation, I mean, as compared to those who have higher GFR. And also what was of interest is donors who are related to the recipient tended to have higher chances of kidney failure as opposed to donors who are not related to the recipient, suggesting that there is a genetic association between the kidney failure and especially in the recipient, which might be probably present in the whole family and might be the one also playing a role in the donor. People also who have a low socioeconomic background tended to also have higher rates of chronic kidney disease or kidney failure. So the risk really is low of developing kidney failure if you donate your kidney, but among certain groups, you can see that the rates are a bit higher, and that brings some concern. On the other hand, as doctors, we largely look at these things. We look at the risk of developing kidney failure. We look at risks of developing hypertension. We look at, we look at death just after the operation and things like that. What do patients look at? They've looked at and I've talked to donors about what they value most. And as you can see, it varies really between countries. This was data that was done between Australia and Canada. Among Australians, they really looked at the most important concern, where anything close to 1 tells you that the donors are most concerned with, whereas 0 means they're least concerned with. And as you can see, the impact on family and the time to recovery was the main reasons among the Australians, whereas among the Canadians, they were worried about what their kidney function would be and what surgical complications were going to come out. So as much as we worry about kidney function, which was probably less of a concern among Australians. As doctors, we worry about these things. It seems like sometimes patients or donors don't really mind them. They might not mind the long-term concerns. So it tells us something that we might need to emphasize when we cancel potential donors. So probably they're more concerned with the operation itself, the pain after the operation, the time to recovery, how soon they can go back to their families, how soon they can go back to their day-to-day lives. And probably they don't worry about the long term, which is good because the data also tells us that the long-term kidney outcomes are not that bad. So in short, chronic kidney disease is a menace, becoming increasingly a problem. Dialysis is what we have at the moment, but it's not the answer. It's just one of the ways to taking care of these patients. So transplant remains the best option. But of course, we need to address risks to the donor. And with proper evaluation and follow-up, these things can be mitigated. And I would actually suggest that probably we need to have discussions with patients, tell them these things that we know, but probably also address some of the concerns that are more important to them, not necessarily concerns that are more important to us as doctors. Thank you very much. And back to you, David.
Thank you very much, Dr. Koech, for enlightening us on that. Thank you for keeping time. Now, donors, the moment they do a nephrectomy, they become CKD patients. Yeah, is this some? I'm shocked that this didn't come up in the US and Canadian, data, that they are not worried that they've become CKD patients all of a sudden. Out of 4 hours, bam, you come out and you become a CKD patient. Do you think this is something that should worry them as donors? And if yes, what can we tell them?
Thank you very much, David. And that's an excellent point that you've come up with. Automatically, obviously, once you have a nephrectomy, you're a CKD patient. And actually, this has been looked at, but as you understand, it's just a term. So actually, there's a study that looked into it and looked at the US data for the donors and looked at the claim forms, insurance claim forms, and and medical records after donation. Most of them would be labeled as chronic kidney disease, but of course, it's just a label. So the more important term is what people think is the more important thing is how many actually go on to dialysis, which is the important thing, especially to us as doctors, because we don't want to have someone donate and then lose their kidney. And as you can see, the numbers are actually impressive. About 80 to maybe 100 and something per million per year end up in dialysis, as compared to 260 plus in the general population. So it tells you that we are not making these people prone to end-stage renal disease, which is the important thing. They will be labeled as CKD, yes, but actually it doesn't pan out to needing dialysis over as long as 20 years, which is good, and that's impressive. What was the other question? I thought there was another issue you raised up.
That was pretty much what to tell them as and when they become that particular category, so to say.
Yeah, so I guess we might need to cancel them. We might need to tell them, look, because you've had a kidney removed, you're at risk of developing kidney failure. That's why we're categorizing you as CKD, but actually CKD 0 or CKD 1. It's not that they have kidney failure. And then we tell them that, but look, your risk of developing kidney failure is probably what? If in a million people, it's probably 100 of you would develop kidney failure. Your chances of developing kidney failure and needing dialysis are very low. And we need to do that. We need to tell them that. And probably we need to address the more pertinent issues that they have. They seem to be more worried. And probably someone needs to do a study in Kenya and look at what these people worry about. They seem to be more worried about the immediate term.
Yeah.
How soon am I going to get out of hospital? Will I be in pain? Will I go back to work? In Kenya, people usually tell you, when can I go back to my wife? Or when can I go back to my husband, which are probably the more important issues to the patient. I think they seem to trust that we've sorted out them and we're really taking care of the risk to their kidney, and they trust that, which we need to continue doing. But for them, probably we need to address the more immediate issues of pain and being in hospital and the time they lose in between and the things they lose due to the operation in the short term, which is encouraging. And this is something that probably surgeons can address easily. Yeah.
And actually, you see this even with their returning for visits. They return in the first 2, 3, 4, 5 months, 6 months.
Yeah.
After that,
yeah, they're done.
Most of follow-up, they're done.
Yeah.
Dr. Koech, thank you so much. It's been a pleasure having you as one of our speakers. We've learned a lot from you. All the attendees, thank you for attending. Our fellow panelists who are here, thank you for being with us. My chairman, also thank you.